Good afternoon and happy Pride to everybody. My name is Karen Parker and I serve as Director of the Sexual and Gender Minority Research Office at the National Institutes of Health. We are so excited for today's scientific webinar series. Today's webinar is part of our Pride celebration in the Sexual and Gender Minority Research Office and will feature research on minority stress and the health of transgender people from the NIH-funded TransPop survey. The TransPop survey is one of the first ever attempts to collect a nationally representative sample of transgender people in the United States. And of course, we have three very distinguished investigators who will be presenting data from the study today. Dr. Ilan Meyer is a Williams Distinguished Senior Scholar for Public Policy at the Williams Institute and Professor Emeritus at Columbia University. Dr. Sari Reisner is Director of the Transgender Research at Brigham and Women's Hospital, Assistant Professor at Harvard Medical School, and Director of Transgender Health Research at the Fenway Institute. Dr. Tonya Poteet is an Associate Professor of Social Medicine at the University of North Carolina at Chapel Hill and is a former member of the NIH Sexual and Gender Minority Research Working Group. Dr. Jody Herman, who is the Reed Rasmussen Fellow and Scholar of Public Policy at the Williams Institute, will unfortunately be unable to join us today due to a family emergency. Dr. Meyer will be presenting the information that Jody had planned on presenting. During today's webinar, audience members are encouraged to submit questions to all panelists using the chat feature. Due to time constraints, select questions will be posed to our esteemed speakers at the end of the presentation. Please note that today's webinar is being recorded. The recording will be transcribed and posted to the Sexual and Gender Minority Research Office website in the coming weeks. And so without further ado, I will hand it over to Dr. Meyer and welcome again to our esteemed guest.
Thank you so much, Karen. And on behalf of all of us, we're super excited to be here and to have been invited by SGRMO and also to be presenting on Pride. So happy Pride to everybody. I will be next. Sorry, I forgot. I'll be presenting first some information about this originally kind of designed sample and how we did it and what lessons we learned from that. Dr. Reisner will then present on sexual orientation measures inclusive of transgender people for population-based surveys, a measure that we designed especially for this survey. As Karen mentioned, Dr. Herman is not able to present, but I will be presenting the findings from this paper on minority stressors that we co-wrote, as well as other people on this on each of these papers. And Dr. Poteet will then discuss a paper on cardiovascular disease. Next. So the TransPop project was something that we designed and thought of for many years and came to fruition thanks to NIH funding by NICHD. It was a kind of daring attempt to get a national probability sample of transgender people. And the unique aspect of that compared to other national samples is not only that it's national, not just select states, as the BRFS says, for example, but we wanted to use survey questions that are specifically designed for transgender population. So normally we would have a survey that is studied across the population, and when it's inclusive of transgender people, we have some representation, but we don't usually have very specific items designed for that. So the aim of the TransPop was, number one, to attempt this two-phase sampling method that I will describe in a second, and second, to collect, obviously, substantive information on demographics, identity, minority stressors, physical and mental health, and transition-related experiences that are, of course, specific to trans populations. Next. The methodology the original kind of innovative methodology was this crazy idea to survey everybody in the US population, the number that we determined would be necessary, in a first phase, which was done by either random digit dialing or address-based sampling. And then after we identify the transgender people that we can and are interested in, that we can include and are interested in studying, those people will be sent a separate survey that will ask those substantive questions. And those surveys were sent either in mail form, physical mail, or physical paper, or online. Next. So this is the schematic overall design, and we use Gallup as our recruiting and survey manager group. And as you see, after the SOGI screen, the sexual orientation and gender identity questions, we selected participants into two studies. Actually, the two studies are related. The generation study included everybody who screened as LGB, who was cisgender, and gender non-binary, but not transgender identified. And in the TransPop, the study that we will be presenting about today, we included everybody who was transgender or transgender non-binary, and across all sexual orientations. So, of course, including queer, straight, LGB, and etc. You'll see some more about the identities lately. I would also point out on the right, there is a sample of cisgender people. That's just but that's a general population sample that we recruited as a comparison sample using the same methodology among people who did not screen as transgender. Next. So we're focusing today on the TransPop, but also, as I said, see some data from the cisgender sample. Next. So this is what we had to do. We interviewed over 430,000 people. That is in that first phase, that screen that allows us to select transgender people. Our questions for identifying transgender people, we used the two-step questions where we first assess sex assigned at birth and then current gender identity. And people who were included as transgender in the TransPop were people who were identified either as transgender or their current gender identity was different than the sex assigned at birth. So, for example, the benefit of that approach is that you would also capture men and women who are transgender but do not identify necessarily as transgender. And you'll see that in a minute as well in our data. So our total population, we identified 0.22%, 929 people. Of them, 72% agreed to participate, which is quite high for surveys of that nature. So almost 3/4 of people said, yes, I'm willing to do a survey on transgender specific questions. Unfortunately, the cooperation rate with the survey, once it was sent to them, was not as high as that, still within the range of what, higher even than what people in survey research expect, but only 41% actually completed the survey. I would also add, we originally identified 326 eligible respondents, but 52 of them were dropped later, so our final sample is 274. The reason for dropping is complex, but we determined that those people were mistakenly included. Either they misunderstood the question, so well, we actually don't know exactly why, but we determined based on a whole range of answers to questions that they were not in fact transgender. Next. So the final composition included 14% men, 17% trans men, 20% women, and 18% trans women, as well as 31% who identify as non-binary. Again, I would note here that these are non-binary people who said their sex assigned at birth was different than the gender identity. We also had a group of people in the generation study that were sexual minorities who later identified as non-binary, meaning their sex assigned at birth and gender identity were the same, so they were cisgender, non-binary. And we have on the Williams Institute website a new report that describes the non-binary population across the two surveys. So if you're interested in non-binary, I encourage you to look at that. Next. The age range was, of course, the entire population, 18 and older, but as we know, there's a very strong skew towards younger people among the transgender population. Races were mixed with less than 60% white. I think a larger than general population proportion of people identified as multiracial. Next. One of the unique things on being able to do a survey that is specifically designed for transgender people is that we were able to include questions about residents and then analyze the residents with the proximity to an LGBT health clinic as a kind of general measure of how connected people could be. Not all LGBT health clinics provide transgender services, but many of them do. And we see that 71% live within that 60-mile proximity, which in some places is not very proximal in terms of the actual ability of people to arrive at such a clinic, but we use that as a general kind of approximation of what is reachable. 58% were partnered, which is similar to what we see in the general population. And of those who were partnered, 42% were partnered with a cis woman, 20% with a cis man, and 38% with a non-binary person. Next. The transgender respondents were more economically disadvantaged. We see that 48% were below the 200% of federal property level, which is quite high, and 23% were unemployed, including those who are not in the workforce. Housing instability was also high, with 15% moving at least 3 times in the past 2 years. Next. So in conclusion, we found that it was possible to get this sample together using this two-phase approach. This, as I said, extremely ambitious interviewing of 430,000 people in the general population yielded a relatively small total sample. The 0.2% that we actually identified was less than what we anticipated based on the BRFSS, but the BRFSS uses a somewhat different measure in identifying transgender people that could partially explain this. We don't, I think, know exactly the reasons, but our measure was pretty, our finding of 0.2% was pretty consistent across different ways of sampling, meaning the RDD and the address-based sampling. I would, of course, note that this is a costly study in terms of screening so many people, even if it uses a very brief measure, a brief survey. But I think it is feasible, and especially if you were to adapt it to a smaller, state-specific or region-specific, it is a very doable and obviously less costly approach. So with that, I would move on next and turn it to Dr. Reisner. Thank you.
Hi, everybody. Thank you, Dr. Meyer and Dr. Parker and colleagues for having us here today. Very excited to talk a bit about some of the measures that we utilized in TransPop that were designed to look at sexual orientation and dimensions of sexual orientation, specifically those that were inclusive of transgender people. Next, please. So sexual orientation, when we're talking about that, refers to a person's enduring emotional, romantic, or sexual attractions to other people. And as many of us know, next slide, we have multiple dimensions of sexual orientation. So for example, sexual identity, how a person identifies their sexual orientation to others. A sexual attraction, the sex or gender of individuals that a person feels attracted to. and sexual behavior, the sex or gender of a person's sexual partners. And we know that these different dimensions of sexual orientation matter for health. We've seen there are multiple studies that show differences in health outcomes by different dimensions of sexual orientation, and really the dimension that we utilize often depends on the health outcome under study. But importantly, in terms of population surveys, often we're limited to surveys where there's a very binary conceptualization, that is man, women, both men and women, including also in clinical care scenarios. So what we sought to do in terms of these measures is really to think beyond the binary and to adapt some of the existing measures through the SMART group, which is the Sexual Minority Assessment Research Team, which was a report that came out in 2009. You can find it on the Williams Institute, to adapt some of those measures and also adapt them to be inclusive of trans people. So next slide, please. So what I'll show are some of the data by the different dimensions here of sexual orientation. So firstly, sexual identity. The next slide will show the categories, but what you can see here is on the left, the transgender population, and on the right, the cisgender population. You can see that the pies are distinctly different. That is to say that the proportion of transgender people who identify as sexual minority in some way, i.e. not heterosexual or straight, is much higher, 82% versus 10% in the cisgender population. And this is really something that we see reflected when we look at the categories breakdown. If you could please go to the next slide. If we look, for example, by transgender, cisgender, and then by gender groupings, so here we're showing trans men, that's TM, trans women, TW, and NB, non-binary, we can see substantial heterogeneity. So firstly, these are the subcategories that are comprising the sexual minority group that I showed you previous slide. But secondly, you can see that overall in the trans population, bisexual, queer, and pansexual were the most commonly, or highly, we should say, endorsed identities. And we can see substantial heterogeneity across the trans population when we look by trans men, trans women, and non-binary people. And this is important for many reasons. This heterogeneity there is great heterogeneity and diversity within the trans population. And when we're thinking about, for example, sexual health studies, when we're thinking about studies that are looking at identity and the complexities of identity, we'll want to consider these subgroup differences in moving forward in population research. Next slide, please. In terms of sexual attractions, we adapted a measure that was utilized in a Massachusetts statewide study, asking people how they, to indicate how sexually attracted they are to the following types of people, meaning by gender and sex. So we categorized here individuals as being somewhat or very attracted to, and you can see the response options, cis women, cis men, trans women, trans men, females at birth, gender queer, and males at birth, gender queer. And you can see that when we ask these questions, people answer them. It's obvious, but when we ask beyond the binary and we don't ask just cis women or cis men, and we break it down further and we look at trans people, trans and gender queer people, non-binary people, we see substantial proportion who are reporting attractions to different genders. This is a check all that apply format, so that's why the percentages do not sum to 100%. Next slide, please. So if we look again by gender groupings here, you can see this is among the trans population. You can look for trans men, trans women, and non-binary people. The highest proportion of folks who are reporting the gender of sexual partners were the cis women. So that's for trans men and trans women. And for non-binary people is females assigned sex at birth who are identifying as gender queer. And what we do see is if we look that the proportion reporting cis women in the trans population as sexual attraction does significantly differ than is significantly higher than for the cisgender population overall. Next slide, please. We also looked at measures of sexual activity, so sexual behavior. Again, important measure when we're thinking about sexual orientation. And what you can see here on the left, the question asked about sexual activity in the last 5 years. And we identified sexual activity as a range of broad categories. So we said in the last 5 years, who have you had sex with? By sex, we mean any activity personally defined as sexual activity. And here you can see that the proportion of people who were not sexually active in the last 50 years. No, not 50 years. We're not talking about 50 years. We're talking about 5 years. In the last 5 years was 28% for transgender population relative to 21% for the cis population. So about a quarter or more, nearly a third. And when we look on the right in comparing the sexual partners of people, we can see again that heterogeneity, the higher proportion of transgender people who are endorsing partners of different genders beyond just man and woman. Next slide, please. And if we look at sexual activity then by partner gender, by gender groups, for trans population, trans men, trans women, and non-binary people, what we can see here is, the proportion who aren't having sex in the past years does differ across the groups, although it's not statistically significant. But what we can see is that in terms of the having sexual partner who are cis women, that the proportion really is higher for trans men and for non-binary people than for trans women in this particular analysis. Next slide, please. So next we adapted a scale that was a sexual functioning scale. It was taken several items, 4 items from the Lauman scale, which is in JAMA, was published in JAMA in 1999. And we adapted some of these for the current study. And particularly what you can see in the blue bars is the transgender population, and in the orange bars, the cisgender population. And you can see that there are lower levels of functioning for trans relative to cis population across, well, in general, not being sexually active in the last 12 months, but also lacking interest in having sex, being unable to come to a climax, experiencing orgasm, and feeling anxious just before having sex. So I just want to say that, what sexual functioning is and sexual pleasure and how we define those and measure those, I think is something that we are continuing to learn and to do. But in this particular sample, we wanted to learn about sexual functioning, which is a very important quality of life issue. And so that's why we included this as a measure. Next slide, please. And again, we're going to look by gender groupings. And what you can see here are that the proportion who were not sexually active in the last 12 months was highest for trans men. For trans women, the highest proportion had a lack of interest in having sex, also for non-binary individuals. Now, what we're not showing you here are the crosstabs, for example, looking among sexual minority groups within the trans population or by gender and sexual orientation. And I think when we're looking at the measures that were designed, these do allow a lot of possibilities in terms of looking at the specific behaviors and identities and attractions of transgender people of multiple gender identities, sexual orientations, etc. Next slide. So what we found is that inclusive measures of sexual orientation that were designed for this study, adapted, really did capture the diversity of sexual identities, attractions, and also activity and behaviors in the trans population. We found, that on average in the trans population, there's greater heterogeneity and diversity of sexual partners, of identities than in the cis population. Importantly, there are notable challenges. We know that there are many challenges to measurement of sexual orientation in all of its aspects. Particular to this study, we have evolving terminology. The pace of language in trans population and trans people is always changing. So, for example, using the term cis, which has really become the norm now, non-transgender was the kind of phrase that preceded that. And so, we'll continue to probably see evolution in language. Likewise, non-binary, was not as necessarily as commonly used as genderqueer and other gender fluid and other identities. So as these change, it will be important for us to make sure that our measures remain relevant and that we continue to make sure that we are keeping up with the changing social categories. It's also important that we look at different groups beyond sexual orientation and gender identity groups. So, for example, by age, and we look by race and ethnicity, very important to look and see about cultural differences, particularly by language and by where people are living. These are measures that were designed for the US, so probably not necessarily generalizable outside the US. and also think about other dimensions and axes of identity where we have intersectional identities, to think about how these measures may perform specifically in those groups. We talked about sexual functioning and the importance of considering sexual pleasure as a first pass in looking at this. This is definitely gives us some prevalence and data to look at the trans versus cis population, and really a call to really talk about healthy sexuality and how to improve that for trans people. Next steps are many. Cognitively testing and validating these measures, certainly. Importantly, assessing associations with health outcomes. I can tell you that in some preliminary analyses that trans people who were identifying as sexual minorities had the highest rates of PTSD, higher than cisgender sexual minority people, and obviously higher than both cisgender and transgender non-sexual minority or heterosexual straight people. So we have much work to do in looking at these data, and these measures really allow for that to happen. So we're very excited to have had the chance to share them with you. I want to also say that these measures are available. The methodology is available, study methodology is available on the TransPop website. So it's transpop.org. There's a tab that's for the methods, and these can be found there, as well as the reference source citations. So thank you very much.
Thank you. I'm back presenting with Jody. As we mentioned before, Jody had a family emergency this morning, so she's really sorry not to be with us here. I want to take this opportunity to mention an announcement that I forgot earlier. So in addition to what Dr. Reisner just said, we have all of the measures on our website. The exciting announcement is that all of the data sets from the two projects are now or soon to be available on ICPSR for the public. So anybody can download this entire data set, the cisgender data set, the generation data sets, as well as a combined data set that has both the TransPop sample and the generation sample. And as soon as I finish this presentation, I will post a few links. We also have a new report on the Williams Institute website and a really beautiful data interactive where you can see some of the findings from these two studies by gender, meaning cisgender men, women, and transgender people. So moving on to the minority stressors presentation. Next. We asked about several measures of stress. Here we're showing victimization. This measure I want to add is over the lifetime. So that is significant because, as I said before, the transgender sample was significantly younger. So even though we see significant differences in being physically attacked, threatened with violence, and verbally abused, these data are weighted for any kind of sampling biases, but they're not controlled for age. So it gives you a good idea of what this looks like in the two samples. But as you know, for lifetime measure, older people has greater chance of having experienced certain things, and therefore will always have higher prevalence of that measured thing. Next. In terms of the reasons for victimizations, we see clear differences in the trans versus cisgender, straight. So this is the cisgender straight. Our cisgender sample actually has some LGBT respondents as well, but this presentation, I'm just showing the cisgender straight sample as a comparison. And what we see is a clear difference. The reason for being victimized, the transgender population, obviously more likely to be because of gender expression and appearance. Interestingly, for the cisgender, physical appearance appears there is number 3, and the top one is their sex, being male or female. Next. For employment and housing discrimination, again, we see higher prevalences for the transgender population in all of these measures. The significance level is indicated with the stars. And especially we see high differences for being denied a promotion, receiving negative evaluation at work, and being prevented from moving in or buying a home. Next. And the reason for job discrimination, again, being transgender is the number one reason. For the cisgender, being age and sex are being the highest reasons for discrimination. Next. Bullying, this is obviously a measure of people under age 18, so it's equal regardless of the age, the current age of all respondents. And we see huge differences in the extent of people being bullied as children, with almost half of the transgender people reporting the top of the bullied. So we have several levels, often, sometimes, etc. This is often almost half of the people. This is not shocking, but it is still devastating to read and see. And again, the reason for bullying was physical appearance and gender expression, appearance, and sexual orientation. Next. This is the measure of everyday discrimination that I think many people are familiar with. It's often used as a kind of temperature taking of kind of the level of exposure of what people now call microaggressions or kind of smaller types of prejudice related experiences. And this is a 1-year measure. So again, the issue of lifetime is not present here. And you see that the differences are indeed much greater between the transgender and cisgender straight sample, with many more people reporting everyday discrimination in the transgender group. Next. And again, past year's stressful experiences, we see large differences. In particular, having trouble with your boss or coworkers, or that's work environment, serious problems with neighbors, friends, and relatives, major financial crisis, which is of course consistent with what we showed earlier regarding poverty, and serious trouble with the police and the law, which is more than double in the transgender population compared to the cisgender straight population. Next. Chronic strains are stressors that are persistent. They don't have a start and end time, so they're different than events. And you see here for transgender people, the most endorsed chronic strains include being alone too much, wondering if I'll find a partner or spouse, and relationship with parents being strained or conflicted. Next. In terms of childhood adversity, I'm not sure if many people are familiar. It's a pretty commonly used measure, adverse childhood experiences, or ACE is it sometimes called. And we see for both the overall measure and for the sexual abuse subscale, the transgender people more likely to have experienced childhood adverse events. And conversion therapy, which of course is not asked of the cisgender, but 19.5% is much higher than what we found for the lesbian, gay, and bisexual respondents, which was about 8%. So almost 20% of transgender people experience some time of conversion therapy or attempts to change their gender identity. This is over their lifetime, so including childhood. Next. So in summary, we're seeing, again, not surprising, but still devastating. Overall, transgender people experience significant minority stressors that can impact mental and physical health outcomes. We didn't show that connection or that association in this particular presentation. But as you know, minority stressors are predictive of mental and physical health, mental and some physical health outcomes. Victimization and discrimination experiences are attributed differently by cisgender and transgender people, with transgender people attributing these experiences to gender expression are obviously more likely than cisgender people. And transgender people have a higher prevalence of stressful life events and chronic stressors. So basically, every measure of stress, we found transgender people experiencing higher levels of it compared to the cisgender population. They're also more likely to report adverse childhood experiences, and almost 1 in 5 were subjected to conversion therapy. Of course, we'd like to see more research, in particular on the relationship of the experiences of these stressors with health outcomes, and hopefully some interventions, especially starting early in childhood with a very high rate of bullying, adverse events, and conversion therapies that children and youth experienced in their past. So with that, I would end this presentation and move it on next. Dr. Petit. And I will, before you start, sorry, I will put a few links in the chat so people who are interested in some of the documents that I mentioned will be able to retrieve them. Thank you. Dr. Petit?
Thank you, Dr. Meyer, and thank you to Sari Reisner and to NIH and the Gender Minority Research Office for hosting this panel. It's really a pleasure to be here and to take us home, I guess, with the last set of findings. If we can go to the next slide, I'll talk a little bit about the findings related to cardiovascular disease in the trans population. So as a background, there are few, I think I'm hearing an echo and I'm wondering if it's possible for Dr. Meyer to turn off his microphone. Awesome, thank you. So there are a few population-based studies of cardiovascular disease in trans populations, with the one exception, well-known exception being the Behavioral Risk Factor Surveillance Survey. And that's a survey that is conducted annually to the entire US population. And there are a set of sexual orientation and gender identity modules that are optional. And the gender identity module is not actually conducted by every state. So it doesn't actually represent a national sample. However, data that have been used to analyze cardiovascular disease among trans populations do suggest disparities in cardiovascular disease risk. However, the BRFSS, because it's designed for the general population, doesn't ask about transgender specific factors such as hormone therapy, and it doesn't ask any questions related to gender non-binary status. So we don't have that data in the BRFSS. For studies that have been conducted with convenient samples of transgender people, the data are mixed on the role of gender affirming hormone therapy and its impact on cardiovascular disease, with the exception that findings have been pretty consistent about associations between exogenous estrogen and venous thromboembolic. And finally, the role of gender minority stress in cardiovascular outcomes hasn't been explored in prior population-based studies. So those are some of the gaps that we hope to fill with this analysis. Next slide. So specifically, the aims of this analysis were to describe the distribution of smoking, select cardiovascular disease conditions, and venous thromboembolism or venous clots, and compare them across gender identities and compare trans with cis adults. We also wanted to look at the effect of psychosocial factors and hormone therapy on the same outcomes in trans people specifically. We examined everyday discrimination, psychological distress, adverse childhood experiences, and hormone therapy. Because of most of the standard cardiovascular disease risk calculators are calibrated for people age 40 and older, we restricted the sample to participants in TransPop who are age 40 and older. We used descriptive statistics to estimate, we used unweighted data to estimate the descriptive statistics, and we used weighted data for all the other analyses. We used multiple imputation for missing data, although missing data was quite low at 0.28 to 7.4%, depending on which variable. And logistic regression models were used to estimate the odds ratio. So when we look at the subsample that was 40 years and older, you can see their demographics here. Even when we limited the population to age 40 and older, we still saw that the transgender participants were younger than the cisgender participants. And this is consistent with what we see in the BRFSS as well. And we also noticed that there were a higher percentage of Black participants who identified as transgender compared to the cisgender participants. And that is also consistent with the BRFSS. And then, not surprisingly, based on what has already been presented, the trans population had lower educational attainment. And while they had similar employment, they had a higher need for financial assistance, suggesting that their employment was not as gainful as it was for cisgender participants. And they had higher scores for discrimination, psychological distress, and AIDS. So looking at these outcomes separately, comparing the trans and non-binary participants grouped together with the cis participants, we see that there's not much difference in smoking, either ever smoking or current smoking between the cis and trans samples, with a slight suggestion that perhaps a slightly higher percentage of cis participants were smokers. However, we do see that there is a higher percentage of hypertension among the cis participants compared to the trans participants. And I have to say that this might also be affected by the fact that overall the trans sample was younger, the trans and non-binary sample was younger. We did see that a greater percentage of the trans and non-binary participants reported having a heart condition, reported having angina, heart attack, stroke, and blood clot. However, for most of these outcomes, I think, at least for me and for many people who do cardiovascular disease research as trans populations, we're very interested in hormone exposure. So in a couple of slides, I'm going to talk about what we were able to find out about the relationship between hormone exposure and some of the outcomes. So we'll break that down as much as feasible. Now, if we look just at the trans sample, thank you. Next slide, if we look just at the trans sample, and compared trans men and trans women, we did exclude the non-binary participants from this analysis because there was such a small number, because we'd restricted to 40 years and older, that the confidence intervals were quite wide and the results could potentially be misleading. So in order to prevent that, we just present the trans women and the trans men findings. So we see that ever smoking is very similar between trans men and trans women. However, trans women were more likely to be current smokers, more likely to have had a higher percentage who had hypertension, heart condition, stroke, and VTE, and trans masculine folks are more like had a greater percentage who reported heart attack. And in the upcoming slides, you will see that when we do the logistic regression analysis, we'll collapse the hypertension, heart condition, angina, heart attack, and stroke into a composite variable for cardiovascular disease because of the small sample size. So you'll notice that changes as we go to the next analysis. Next slide. So here we're comparing cardiovascular disease, any cardiovascular disease outcome among those that were listed in the prior slide, VTE, and smoking by gender identity. And you can see if you compare trans participants versus cis participants, you see a higher proportion, a higher odds of having a VTE for trans participants compared to cis. And this is largely driven by the difference between trans women and cis women, with almost a 4-fold higher odds of VTE among trans women compared to cis women. Next slide. In this analysis, we looked at relationships between the stressors that were beautifully outlined by Dr. Meyer earlier and some of these cardiovascular outcomes. And I was surprised to find that everyday discrimination actually did not have any significant association between everyday discrimination and cardiovascular disease outcomes. And that might be because the questions were limited to the prior year, and we know that chronic cumulative stress is the highest effect on cardiovascular disease. However, we did see that for both cis and trans people, there was relationships between psychological distress and cardiovascular disease conditions, with a slightly higher odds ratio for transgender participants. We also noticed, interestingly, that for trans participants, current smoking was associated with psychological distress, and for cis participants, ever smoking was associated with psychological distress. And of course, it's impossible to determine directionality with a cross-sectional study. So it could be that people had greater psychological distress when they had these experiences versus the other way around. However, what it is possible to determine directionality would be something like ACEs, because they are experienced in childhood. And here we see that among the transgender participants, the higher the score of ACEs was highly associated with current smoking, with a 60% increase compared to cisgender participants. Next slide. And here is where we did the best analysis we could of gender-affirming hormone therapy and its relationship to cardiovascular disease outcomes. And again, we break it out by specific outcomes here. We are comparing in this table trans and non-binary people who ever took hormones to those who never took hormones. In all cases, as you can see, those who took hormones more often reported one of the listed cardiovascular disease conditions. Then we did a logistic regression analysis looking at cardiovascular disease outcomes as a composite variable, and then venous thromboembolism as a separate variable. We can see that transgender respondents with a history of hormone use had a lower odds of any cardiovascular disease compared to those without hormone use, and a history of hormone use is associated with the higher odds of VTE. Of course, this has its limitations. There are small sample sizes, as has previously been mentioned, which precludes any disaggregation by gender identity. There's a lack of detail on what hormones people were actually taking, how long they were taking them, what dose they were taking them, and those types of things. So this is really just a broad look at any potential relationship. So next slide is in conclusion. To recap, we found a higher odds of VTE driven between trans and cis people, driven largely by higher odds of VTE in trans women. We saw that ACEs increased the odds of current smoking for trans people. The psychological distress increased the odds of cardiovascular disease and current smoking. And together, these findings support the minority stress model. As I mentioned, there were the limitations that have already been described, and there's a need for further research that has larger samples, longitudinal data, validated outcomes versus self-report, and hormone specificity. And we hope that this has been an inspiration for funding for those types of studies going forward. And I think that I am done, and we have some time left for questions.
Great. Thank you so much, Dr. Poteet, Dr. Meyer, Dr. Reisner. Truly, we're getting lots and lots of really amazing comments that, you know, these results are just really great to hear. So a couple of questions that have come in. So one question that came in has to do with the way that you measure the distance to a health center and whether or not you would do that sort of as the crow flies, like a direct line distance, or whether you would do that sort of how long it would take somebody to get there driving, for example. If you could talk a little bit about that measure, that would be helpful.
Yeah, this was a direct line. We couldn't, well, I guess we could have, but, you know, with transportation being so different, you know, 5 miles in New York City can be harder to access than, you know, 60 miles in a more rural area. So we just did a very broad distance on a map. And we have a few papers. We have a paper on, I will send the link if you're interested, on the health clinics and their locations across the United States. And that's what we use as our clinic location. So other than that, we just looked at a very global measure of distance. Thank you.
Great, thank you. And there are a few different questions that are sort of coalescing around the idea about race, and was race used as a confounding variable? Was it considered related to the questions that were on victimization? Sort of how that played into the study.
Well, let me answer this globally. Again, this presentation we just did was of the entire population. And as you can imagine, we're working on many papers for both studies, as are many other people at this point. I just posted the data availability on ICPSR, We had over 10,000 downloads on the generation study, which has been there for a few months. So I'm expecting many more papers to be published. But of course, race is a hugely interesting and important variable that we would look at. But at this stage, we just provided today the total sample statistics, and they were not adjusted for age or race or anything else.
Except the cardiovascular disease one was.
Right,
that-
right. I'm talking about the demographics, sorry.
Okay.
Yeah, and so Dr. Poteet, there is sort of a follow-up question about that, the cardiovascular piece. So hang on, people are adding questions and then my thing scrolls to the bottom. So now I have to find the question again. So somebody was asking if the differences in cardiovascular health could also be driven by either a lack of access to or unwillingness to access care due to discrimination, experiences, those types of things.
Absolutely. We did not have a measure of that. We had this sort of accepted, validated everyday discrimination measure, and we didn't. At least I didn't look at it in relationship to delaying access to care. But that is a really interesting analysis, and I think we do, Dr. Meyer, have the data to look at that. So, yeah.
Right. So additional future research.
Yes.
And someone's asking about the involvement of trans and non-binary folks in the design and analysis of this study. If you could talk a little bit about how the community was involved, that would be great.
We had we did. It wasn't a community-based participatory study. It was we had advisors that we consulted, and that are listed on the website, but it was not a community-based study, and not a CPR, not a community-based participatory research method.
Okay, thank you. And then a couple of people were asking sort of about the future of this work. Are there plans for this to be an annual survey, or sort of what's the future of TransPop and generations look like?
Well, Karen, all we need is the money. We are actually looking at a continuation grant that will focus on what some of the question was, on disparities by race, ethnicity in both studies. So the two studies which are overlapping because they have many similar questions where it was possible. Obviously, we don't have transition-related questions in the cisgender sample, but together we're calling it the LGBTQ sample, and we are looking to continue this with with existing sample with focus on health disparities. In terms of new samples, I see a lot of questions. I think, well, we don't have any plan at this moment, but I think, as I said before, it's a promising and probably less costly if you did it in a more restricted region, like a state or even a city.
Great, thank you. And somebody is asking, let me find it again. Somebody's asking about any measures of adversity, right? So that some of this work is kind of demonstrating resilience and adversity, and whether or not there were data from participants on dimensions that promote well-being. And if you could talk at all about that.
Well, in terms of adversity, we have a lot of measures of stress, which is, I think, synonymous with the word adversity. In terms of resilience, we have measures that, in my sense of resilience, is really a lot of it has to do with resources rather than individual kind of qualities that person brings. So this is a focus that we had in this project, in the two projects. Well-being, we have a few questions there. So those can be, again, those are still a lot that we need to analyze. By the way, the link that I just put for the LGBTQ sample, which has all the data for transgender people, again, has a lot of information on some other variables that, on many variables that we did not discuss today. We also have a paper, I think it's already been published. Yeah, it has been. And it looks at healthcare and health access. Jamie Feldman is the first author, and some of us are co-authors. And can somebody remind me where it was just published?
Andrology.
Thank you. So yeah, we're working very hard on releasing, as I said, both papers, the data itself, and reports. We have the visual interactive data in the Williams Institute website that I shared. So we do have a lot of data, and we've also had dissertation projects working on various aspects of this. And as I said, right now we released all of the data to the public, so we'll likely see a lot more. We have a paper on parenting. I mean, I don't want to list all the papers that we have either in the works or already out there, but again, the Transpop website that Dr. Reisner mentioned has tabs where you can see publications as well as the entire methodology, and the actual instrument is listed there, as well as a Spanish translation of that instrument. So I think it would be a good resource for those of you who are interested.
Great, thank you for that. Well, we're at the end of our time today. So I would just like to remind folks that you mentioned this this data is available. And so folks who are interested in sort of looking more broadly at all of the data that was collected and thinking about some maybe unique research questions that they're interested in, they would have the opportunity to do so. So what an amazing resource. So I just want to thank you again to our invited investigators for taking the time to be with us today. Thank you also to all of our audience members for your participation, for your really great questions. Again, I apologize we didn't have time to get to all the questions. As I previously mentioned, a captioned video recording of today's webinar will be posted on the Sexual and Gender Minority Research Office website in the coming weeks. If you are not a member of our listserv, I would encourage you to sign up. You can do that and stay informed of not just when this recording is released, but also other important updates related to SGM health research at NIH. A link to register for the listserv is on the homepage of our website. And finally, just thank you again and happy Pride. And I hope to see you all at our next scientific webinar.